In acute leukemia, as I said, this is a key point. So a patient who does not become MRD negative in an acute leukemia is a patient that will relapse. So we need to have MRD negativity. So what are we doing? I mean, conventionally, and the guidelines say that the optimal is by quantitative PCR, so molecular, which in ALL is doable across the board practically for all ALL patients. In AML, it's more complicated because we don't have one genetic marker or two. We have different subfractions. Some can be monitored, some cannot be monitored. So in AML, a lot of centers use flow cytometry, which we consider overall less reliable and less precise. And indeed, in ALL, it's not usually done. We do molecular monitoring. So that is what we are supposed to do. The problem will be when this becomes clinical practice. So who's going to do it? I mean, if it's in a clinical trial, as I said earlier, it's done centrally in certified laboratory with standardized technology. If you do it in a real life, and if that is a measurement of failure of treatment or we need extra treatment, it has to be done in the best possible way. Who's going to do it? So I think this is a real challenge, going from a clinical trial to the daily practice. And as I think I said earlier, we have a drug approved for MRD in ALL, which is blinatumomab. It's a form of immunotherapy, and it's been approved by FDA and by EMA for management of MRD-positive leukemia in ALL. So if it's approved, it means it can be utilized in a day-to-day activity in any center. But who's going to test the MRD? So MRD is technologically advanced. If it's molecular, it means that, for instance, in ALL, you have to sequence the breaking point of each patient. So it's cumbersome, complicated, you need expertise, costly. So it has to be done well. So if I want to look ahead, I see this as a major issue, because if a compound is approved, then it's for everybody in theory, at least for the lucky countries that can afford it. The problem is who's doing the MRD. So I think we are at a time now that we are really moving towards a MRD-driven era in hematology, which extends far beyond the acute leukemias. I mean, in CLL, it's been done very frequently. So we have to now challenge now that having laboratories that are set to do it. As I say in meetings, I think every region or country should have reference laboratory, because everybody cannot do everything. So this, I see it as a primary challenge for optimal management of patients for whom MRD negativity could be achieved.